As a group at Crownview, in the residential program, in the outpatient program, medications have limitations and a lot of side effects. And so a lot of times it takes some talking to families and talking to the clients and getting everybody on the same page. So we have a strategy in that we try to get everyone aligned that is around this client so we can get them treated. Oftentimes a person with schizophrenia doesn't realize they have schizophrenia. Oftentimes they don't have the insight into their condition, and things are very real that is in their reality, it's real. In our reality, it's not so real. So we try to get them on medications. We try to get them into therapy, and we try to get everybody around them. Now, part of what we do, and I think the reason why we're so successful is that medication wise, I mean, really, it's our medications are limited. Like, we have a new medication that's come aboard, but I'll talk about that in a minute. But most of the medications that we have to do with blocking dopamine. And the dopamine in the mid part of your brain is what gives you these sort of what they call positive symptoms of schizophrenia. Later on, you can get negative symptoms, which is a part of the frontal lobe of the brain, the frontal cortical area, which has decreased dopamine. So in one part of your brain, you get increased dopamine. On the front part of your brain, sometimes you start decreasing dopamine. So sometimes as this disease process progresses, people get a lot worse, and they also become very numb, and they become like almost walking shells of themselves. And so you really want to bring up these medications. So medication-wise, it's very simple. We have a lot of different medications, but they all virtually do what we want them to do, is block dopamine or block that pathway for dopamine. Now, on the housing side, when they come into our housing, we have a whole staff of people that have been trained on dealing with people who have schizophrenia, how to approach them, how to talk to them, how not to be confrontational, how not to just endorse their symptoms, but be more empathetic and sympathetic with their symptoms. So we have trained people on both sides of this. So when they're in housing or they're in the clinic getting therapy, we've had training on how to deal with these kind of things. I think that's why when we have someone come in and they start to get better, and a lot of times they call them miracles. For me, it's about really get them on a medicine consistently, because if you don't, this condition is going to get worse over time, and it's just going to keep going and going back and forth. We want this to be people's last stop and their last treatment center, so this person that we're treating can go on and have a functional life rather than the dysfunctional things that they've been going through, in and out of hospitals, in and out of programs, in and out of whether they're on the street or not on the street. I mean, these people have been very compromised, and they are vulnerable people, not only because of their condition, but because they don't understand that their condition actually needs treatment. So if you stand with the family, you stand with whoever loved this person, and you kind of move that way, we help the client move in the same direction. A lot of parents are at their wits' end. They've been dealing with this for years before they come to us usually. Usually it's not just the first program most people are at in our program. Usually it's like they've gone through 4 or 5 without much success, or it's been bouncing around from one thing to another. The first thing we do is we start talking and we start guiding the parents on how to deal with this. And oftentimes, if there is leverage, we try to use that leverage to convince the client to take medication. Because the first step is that you've got to get some kind of medication to decrease the dopamine in the mid part of the brain so that hallucinations or delusions start to come under control. Then, once we understand what the leverage is, we can start approaching the patient or the client, and also be able to help them say, hey, this medication, this is what it does. We need your buy-in on this. Oftentimes it takes multiple conversations. It's not just one time you get to talk to somebody and then convince them that they need to be on a medication when they think there's nothing wrong, but the whole world is out to hurt them. And so we've got to build trust. We've got to build empathy. We got to build a relationship with somebody. That's the real key here. So for me, medications aren't the difficult part. For me, the difficult part is getting someone on a medication, staying on it for a good amount of time, and convincing them that they actually need to be on something for a long period of time. If you've ever been through this before, and if you are a client that's ever been through this before, you realize there are medications that people have given you or given their loved one, and they have taxed them in having side effects, whether it's a tremor or a tightening of muscle or blurred vision or something that goes on, and it becomes a problem. So oftentimes we can kind of try to get to the lowest minimal effective dose, but sometimes it doesn't work out that way. Sometimes people require high amounts of medication. So with the new medication they have, it's called Cobenfy. And Cobenfy doesn't work on blocking all the pathways that cause a lot of those side effects. What Cobenfy does is it introduces something into the brain, which is mostly the front part of the brain, and then it allows the mid part of the brain to decrease the amount of dopamine in the area. It works a lot differently. It's a cholinergic medication rather than an anti-dopaminergic medication. That means that you're not going to be developing things like hand tremors or tardive dyskinesia, or sometimes you get increased prolactin, which increases lactation. You don't get those kind of side effects, but it does have a side effect profile. When they first developed it, there was Emergent-1 trials. They first developed this medication, and they had it all by itself, and they had all kinds of cholinergic side effects like flushing and diarrhea and all kinds of just not things that people would want to take. And there was a lot of people that were dropping out. So what the company did was they added on another medication to decrease that problem, but they used it in a way that it doesn't cross the blood-brain barrier. So it only works downstream. And so it has an anticholinergic effect downstream, and it has a cholinergic in the brain. So downstream, but you do get side effects from either way. Lots of dyspepsia, lots of stomach discomfort, sometimes nausea. You've got to start off a little bit slow. Sometimes I don't use their protocol, but I use our own, where we kind of go a little more slowly to get the person to adapt to it. But it's an excellent medication, and it works really well, but you have to be able to know how to use it. Now, the problem that a lot of people are running up against is that when this medication is not working fully, then where do you go? Because a lot of medications that we have an anticholinergic centrally effect, a central anticholinergic effect, and you're going to counteract the effect of Cobenfy. So sometimes you can marry Cobenfy with medications that have a very low anticholinergic effect centrally, and we've been doing that too. I think Cobenfy is an excellent medicine, but when you deal with people with diabetes or high blood pressure, oftentimes one medication doesn't solve our issue. And we're notorious for being polypharm, but it's for good reason. Because even with blood pressure issues, oftentimes you have to use 2 or even 3 medications to get people's blood pressure under control. And that's just the nature of the beast. So with that being said, I try to minimize the amount of medications people have, but oftentimes you have to be able to treat them and treat them therapeutically, which may require another add-on. And oftentimes when I add on things, I'll add on lower doses. So it doesn't always require high doses of both medications. Sometimes it's just a small amount of medication and marrying them together that really works well. So at Crownview, when we started 10 years ago, we've got a large number of people who've had schizophrenia that are actually working and making 6 figures in the world and functioning. And so they'll continue seeing me, my outpatient practice, and we'll continue them down that road. So it's really nice to see people going from a point where they're completely not functioning, get them treated, get them psychologically treated, and then watch them sort of flourish, whether they're going back to school or whether they're going to work. I've got a guy that was schizophrenia that's in medical school. And so it could be done. I've seen it. And that's what we try for.